and hear me okay? And I'm very honored to be here today and share some thoughts and ideas with you, and to kind of kick off this supporting client health and wellness group of trainings. So as Jen said, we're going to focus on mental health for the first few of these. And today we're going to talk about certain mental health conditions in regards to these diagnoses, what the symptoms are of these particular conditions, and then just some very brief ideas about treatment. And we've actually kind of divided this into two parts. So I'm going to talk about half of the diagnoses today. Jen, I think, will be following up with talking about medications used for those particular diagnoses. And then I'll be coming back in a few months and discussing the second half. And then Jen will follow that up with talking about the use of medication with the second set of different mental health diagnoses. So again, this is pretty much an overview. So I know we're going to be going rather quickly. And if you do have any questions, I encourage you to ask them as we go. And I will also allow a few minutes at the end if you do have any questions and you'd like to touch on a particular diagnosis or another. We could certainly address those at the very end of our time together today. So next slide, please. So these are the general categories of mental health diagnoses. And you may be familiar with some of these, or you may be familiar with all of these, or you may be familiar with none of these. But, and it really doesn't matter at this point. We're just trying to go over what these categories are, so we have kind of a common language when we talk about mental health conditions. So the general categories of diagnosis, and actually I'll be discussing the first four today, and that's going to be psychotic disorders, mood disorders, substance abuse disorders, eating disorders. And then part two will be covering the rest of the categories: anxiety disorders, trauma disorders, which actually we used to categorize under anxiety. Now it's its own separate category. Neurodevelopmental disorders, and those are disorders that we find occurring in childhood and adolescence. Neurocognitive disorders, disorders such as dementia, fall into that category. And then probably everyone's least favorite kind of disorder to deal with in any kind of setting, including a residential setting, personality disorders. So like I said, I'll be talking about those first four categories today: psychotic disorders, mood disorders, substance abuse disorders, and eating disorders. Okay, next slide, please. And one of the things I'd like to mention right at the beginning here is when we talk about mental health diagnoses and psychiatric conditions, there's certain special issues and considerations that we have to make when we're talking about folks with IDD or with a developmental disability, because it actually gets a little trickier in terms of making an accurate diagnosis. And it's certainly trickier in terms of mental health professionals getting the necessary information that they need to be able to make the diagnosis. And so I just wanted to discuss a few of these issues here that make this a rather sticky wicket and a complicated area. And the first bullet point is something that I think is incredibly important to be aware of, which is that psychiatric disorders in people with developmental disabilities are often underdiagnosed or misdiagnosed. So the information that we have about folks that are duly diagnosed, have both a mental health condition and a developmental disability condition, the ones that we've identified, that number is probably lower than it should be, because it tends to be underdiagnosed. One of the things, I didn't have it down here, there's a concept called diagnostic overshadowing, which means that when you have a developmental disability diagnosis, if we see a symptom that in sort of a non-DD person may be considered psychiatric, we tend to attribute it to the person's developmental disability instead of looking closely at whether or not it might be psychiatric in nature. So sometimes what happens is somebody has an intellectual disability, let's say, every symptom that we see, we sort of categorize under that category of their developmental disability, when in fact that may be accurate, but it very well may not be accurate. So we do think that psychiatric disorders are underdiagnosed in the population that you all serve and that we serve at the regional center. It's very true that people with developmental disabilities can experience the same psychological disorders as the general population. There's no special categories of psychiatric disorders that folks with developmental disability experience. It's the same. It may be manifested a little bit differently, but people that have in the neurotypical population, what we call sort of normal population, that have an anxiety disorder, have certain characteristics of that disorder, and people that have a developmental disability that have anxiety also have some of those very same characteristics. So there are no separate grouping of psychiatric disorders for folks with DD. We just have one group, and we try to very carefully look at how this manifests itself with folks that don't have a developmental disability. And then within our work, all of our work, we're working with folks that do have a developmental disability, and we should be aware of the manifestations of these potential psychiatric disorders. One of the problems, and you see this third bullet point, that when a mental health professional, like a psychologist like myself or psychiatrist, when they are trying to figure out what kind of diagnosis a person might have, we tend to be very dependent on the person's verbal report of their symptoms. And that's what SX is shorthand for symptoms. So the best way to get information from somebody about their symptoms is, of course, to ask them. So if we're looking at something like depression, then we might ask questions about, have you ever felt sad or blue? Have you ever felt so badly that you thought about killing yourself? Those kinds of things. And we're very dependent on the verbal report of the client. Well, this is a little bit problematic when it comes to folks with a developmental disability, particularly folks with ID or even, severe or profound ID that can't communicate or don't communicate much or at all. We really have difficulty getting a lot of information from the client themselves. And sometimes folks with a developmental disability might not be the most reliable reporters in the world. They may not be aware of exactly what they're experiencing. And sometimes, and you've probably seen this in some of the settings that you all work in, sometimes they might even exaggerate or fabricate symptoms. So whereas we would typically rely heavily on the patient, their client's verbal report, we really can't do that as much with folks that have a developmental disability. And we have to be very good about gathering information from other sources. A good source of information about our clients, if they're in a residential setting, is you all, because you see them and you live with them and you observe them daily. That's great information. We could get great information from their history or great information from their family about them or from their medical doctor. But we really have to do a little bit deeper digging in some of those areas to get the fullest, best picture of what's going on with that person. So these are just some of the things that are special issues or considerations, and some of the things that make it a little bit challenging or more challenging to get an accurate mental health diagnosis in the clients that we work with. All right, next slide, please. So this brings us to our first category, which is the category of psychotic disorders. And an easy way to think of psychotic disorders is when a person is psychotic, they are really out of touch with reality. So this is a disorder that is lots of times fairly apparent. Most of us spend most of our time in reality, hopefully. So when someone says something or behaves in a way that doesn't sort of jive with what we know to be the case and the truth of the world and the way they act, and they're out of touch with reality, that's really the person who is experiencing some kind of psychosis. A psychosis is a really serious mental health condition, and it's one that is, like I said, fairly apparent, and it is really impactful in terms of the person's behavior and person's adaptive living skills. And so the probably the most common of the psychotic disorders is one that you've all heard of, which is schizophrenia. And there are two hallmark signs and symptoms of schizophrenia, and they are delusions first, and second, hallucinations. And an easy way to think about this are delusions are false beliefs. So let's say when a client says, I think I'm Jesus Christ, that's obviously a false belief, and that's a delusional belief. That is very out of touch with reality, and very we would categorize it as grandiose. They're thinking that there's someone who was a lot of people believe is the savior of the world. So that's very delusional. So delusions are false beliefs. Another false belief that's pretty common with someone who's paranoid is that people are following them, people are out to get them, people have implanted wires in their head to hear their thoughts. Those are all delusions or false beliefs. Hallucinations, on the other hand, are false sensory perceptions. So there's five senses, and you can have hallucinatory experiences across each of those five senses. The two most common kinds of hallucinations with people who have schizophrenia are first auditory hallucinations. Sometimes we refer to that as hearing voices, and second, visual hallucinations. And auditory, far and away, is much more common than visual. And then the other three, which would be taste, which is technically called gustatory, feeling, which is called kinesthetic, and what's the last one that I'm missing? Oh, smell, which is olfactory. Those kinds of hallucinations are actually very rare, and they tend not to happen as much in schizophrenia as they happen with people that have pretty significant brain damage. So the ones that we'll see most typically with people who have a schizophrenia diagnosis are either auditory or visual hallucinations. So a person with schizophrenia tends to have both delusions, false beliefs, and hallucinations, but sometimes they just have one or the other. And obviously that brings them out of touch with reality, and it's very, very impactful. Typically, schizophrenia first occurs in late adolescence, early adulthood. It's very rarely diagnosed initially after early adulthood. So if you're working with adolescents or young adults, first break, in terms of having a schizophrenic break is typically in that late adolescence, early adulthood area. A second kind of psychotic disorder is something we call schizoaffective disorder. And breaking down that word of schizoaffective, the schizo is kind of the schizo of schizophrenia. Affective has to do with mood. So we haven't talked about mood disorders yet, we will, but schizoaffective disorder is a combination of a person having delusions and or hallucinations, and then having some kind of significant mood disturbance like bipolar disorder or depression. So there are kind of two subtypes of schizoaffective disorder. You can have schizoaffective disorder, bipolar type, or schizoaffective disorder, depressive type. And that also is a very significant and highly impactful diagnosis, again, because it really is affecting the person's thinking in terms of delusions and hallucinations and their mood. And so that's a fairly common, you won't see that as often as you'll see schizophrenia, but I've seen schizoaffective disorder diagnosed fairly commonly over my years of experience being a psychologist. Another one that we'll sometimes see is what we call substance-induced psychotic disorder. And that, of course, means that when you're not under the influence of a substance, you're not psychotic, but you become psychotic under the influence of a substance. And in our area and in a lot of areas, the most common drug that we see that causes this kind of short-term psychosis is methamphetamines. A person can take quite a bit of methamphetamines and actually experience psychotic symptoms. A long time ago, I used to work in a psychiatric hospital setting, and it was interesting because we'd have someone come in with delusions and hallucinations. And one of the questions we asked ourselves is this somebody who has schizophrenia? Or is this somebody who maybe has, particularly if they have a drug history, has taken some meth and they're psychotic as a result? And there was a very, very easy way to tell, which was to wait about 48 hours, because at that period of time, if they had been using a substance like meth, it's out of their system, or most of it is, and they suddenly become non-psychotic. If they're schizophrenic, 48 hours would not make a difference. So, but we do see that kind of psychotic disorder as well. And in terms of treatment of these psychotic disorders, I won't go into the specifics because that's what Jen will be doing the next time. But probably the primary form of treatment particularly for schizophrenia, is medication. And there are a lot of different kinds of medications that are used nowadays to treat psychotic conditions. Over the 30 years or so that I've been in practice, actually, we've made great strides in terms of improvements in medications that act more specifically, medications that have less side effects. In the old days, the medications that we used to use had some pretty horrible side effects, and people had to be medicated not only for the schizophrenia, but then they oftentimes had to be medicated for the antipsychotic medication they were taking and the potential side effects. So they had to be on a couple different medications. So there's much better medications. Like I said, Jen will be going into that when she gives her next talk. Another thing that's used is what we call milieu treatment. And milieu just means your surroundings. And so one of the ways in which schizophrenia and schizoaffective disorder and substance-induced psychotic disorder, for that matter, can be treated is by having the person in a safe, contained environment. So things like hospitalization, day treatment programs. Day treatment programs are programs that, as opposed to just getting 1 hour of counseling, the person is at a program for anywhere from 3 to 6 hours a day and getting both probably some medical treatment in terms of medication, some support, some education, et cetera. And milieu treatment is very, very effective for psychotic disorders too. And supportive psychotherapy. Supportive in terms of lots of times when a person has a condition such as schizophrenia, that certainly affects the whole family. So doing some education about what the disorder is, about how the disorder is treated, and what kinds of ways the family can help the person, help the individual with that really serious mental health condition. Something like supportive therapy is very, very important. So again, psychotic disorders, we talked about 3: schizophrenia, schizoaffective disorder, which is that combination of delusions, hallucinations, and some mood problems, and then substance-induced psychotic disorder. Okay, next slide, please. And in terms of, are there any special considerations for our population? I mean, do these kinds of conditions manifest themselves any differently for the folks that we're supporting? And there's a couple things to just keep in mind. One is any significant change in behavior, we need to be alert to that, because that could mean that something is happening like a psychotic break. If you see a really significant, serious change in behavior, particularly this first bullet point or sub-bullet point, increased aggression, self-injurious behavior, or bizarre behavior. a significant change that entails any of those kinds of things is really something to consider. And it might be especially difficult to tell sometimes with people that might have severe or profound ID, but we have to look into this as deeply as we can. And it's interesting, we have a group that has actually come up with a diagnostic manual where they look at these special considerations for folks with developmental disabilities. And in regards to psychotic disorders, one of the things that was mentioned is that self-talk among neurotypicals or normals or non-DD population, self-talk is not quite as common. Among our population, it's very common. So we don't want to automatically interpret self-talk as, oh, the person is having a psychotic disorder, but we do want to consider that. So that's just one difference. That self-talk, talking to oneself or answering oneself, tends to be a lot more common with our folks just regularly than it does the neurotypical population. Okay, next slide, please. So a second and rather big category is that of mood disorders. And this first slide here in terms of mood disorders, we used to divide up mood disorders into two kind of big areas, what we used to call unipolar depression and then what we call bipolar disorders. And the idea was they're unipolar, we're just one pole. The person that has that kind of problem is only depressed. They only experience one end of the spectrum, that depressive end of the spectrum. Whereas people that have bipolar disorder experience both the depressive end of the spectrum and the manic end of the spectrum. You don't hear it talked about that way anymore. I find it kind of useful, I think, to break it up in that way. And so when we're talking about depression, we're talking about two basic disorders. We're talking about major depression and we're talking about dysthymia. And basically, both of these forms of depression are characterized by the same kinds of symptoms. And those symptoms are mentioned in that third bullet point there. And I'll go over those in a second. The difference between major depression and dysthymia is major depression is acute and severe, and dysthymia is much more chronic and low grade. So with major depression, acute just means that it tends to come on suddenly. And severe has to do with the impact of the mood disorder on the person's life. So a person with major depression, for instance, may get depressed very quickly, and they may be really immobilized by their depression. Maybe they can't get out of bed. Maybe they can't go to work or to their job because they just have no energy. Those would be characteristic of this more serious disorder of a major depressive disorder. Dysthymia, on the other hand, is much more chronic and it's low grade. People still have the symptoms and the symptoms can be impactful. They're just usually not quite as impactful as someone that has a major depressive disorder. And so some of the symptoms that you'll see with both of these conditions, with both major depression and dysthymia, and I should tell you, there are other varieties of mood disorder too that I didn't put on here. There's something called seasonal affective disorder. You maybe heard of it. Of course, the acronym is rather appropriate for seasonal affective disorder, which is SAD. And that's the kind of depression that people get typically in the fall and winter months. They're usually not depressed in the spring and the summer, but they can become on a regular sort of yearly basis depressed during the fall and winter months. And one of the things that, of course, we've discovered about seasonal affective disorder is that it tends to be related to light and the availability of light. And if you think about it during the winter months when it's getting dark before you leave the office and there's very little light during the day, we found that that sort of correlates with higher degrees of this kind of depression. And the treatment, of course, is getting more light. Even artificial light is artificial, but as natural as possible, is helpful. So I'm not really going to talk about that in any great detail. You don't see seasonal affective disorder that commonly, but major depression and dysthymia you do see chronically, and you'll see it certainly with our clients. And so in terms of the symptoms, what do you see when someone's depressed? Well, first of all, their mood is depressed, their mood is sad, their mood is blue. I have a really million-dollar word here next, anhedonia, which means lack of pleasure. So people that are depressed, the things that used to bring them pleasure don't any longer bring them the same kind of pleasure. They just don't feel, energized by the things that used to really turn their crank. A lot of times you'll see people that had been, before they were depressed, had maybe had a really passionate hobby. I remember treating one lady who was really into gardening. That was her passion. And when she'd become depressed, she'd stop doing that. She'd stop tending to her gardening. She wouldn't go out to the garden. She wouldn't weed. She wouldn't water. And that was a surefire sign that she was feeling badly. So depressed mood, anhedonia. And actually, they've done some studies, and pretty much the symptom that most people complain of the most subjective distress about is this anhedonia, is just not being able to feel pleasure, which when you think about it, that's a sort of numbing feeling. It's horrible. Next symptom, appetite or weight change. And that can be weight loss or weight gain. Typically, a person that is experiencing a mild depression might gain a little weight. People that experience more moderate to severe depressions tend to lose weight. So that's just another thing to look out for when we're working with people that we believe, and we're looking at them and thinking that they may be depressed. If you see that change in appetite or weight, that might be a sign that they are experiencing some depression. Both from an anhedonia perspective, food just doesn't taste good anymore, so they don't tend to look forward to eating, and then they may lose some weight as a result. Another symptom is either insomnia or hypersomnia. Insomnia is having difficulty either getting to sleep or staying asleep. People that have depression that have usually some anxiety connected to their depression will have some insomnia lots of times. People also can sleep too much, which is what hypersomnia is. I remember a long time ago when I was in private practice and treating people for depression on an outpatient basis, I had a client that would sleep 12 to 16 hours a day when she was depressed. That's a lot of sleep, more than you need, and that's hypersomnia. I didn't put it on here, but another thing you see sleep-wise is something we call EMA, or early morning awakening. People that are depressed tend to get up a lot earlier than they planned on, and then not being able to go back to sleep after they get up, and that's referred to as early morning awakening. Sometimes you'll see psychomotor retardation or agitation. And as you'll see with the next slide with our clients, one of the things you have to be on the lookout for is it's more likely that our folks that have a developmental disability will express their depression with agitation, more so than the neurotypical population. Fatigue or loss of energy. People get tired more easily, just don't have the energy to do things. Feelings of worthlessness or inappropriate guilt. A certain amount of legitimate guilt's okay. Inappropriate guilt, not okay. Feelings of worthlessness, not okay. Difficulty concentrating. Usually people, when they are depressed, have difficulty working or working at the levels that they used to be able to work because of the difficulty concentrating. And then sometimes people have recurrent thoughts of either death or suicide. And obviously recurrent thoughts of suicide is a very serious symptom. because depression is one of the psychiatric conditions that can, in the end, lead to something fatal like a completed suicide attempt. So those are the symptoms. And again, those symptoms are present. I think you have to have 5 or more in either dysthymia or major depression. And the difference between major depression and dysthymia is more the onset being either acute or chronic, and how severe the symptoms are. Regarding treatment, Jen will talk about antidepressants, which have been proven to be not a panacea, but very effective. Psychotherapy is very effective, particularly cognitive behavior therapy. And interventions like cognitive behavior therapy can be used for our population, mild ID, autism, not so much moderate, severe, or profound ID, but mild ID folks tend to do well with that kind of intervention. Another treatment for depression, which is actually free, is exercise. One of the things that people tend to do when they get depressed is actually be less active. And in a cruel twist of fate, one of the things that can make them feel better is to be more active. So the trick is how to motivate people to get out there and move around and exercise, because, and I think all of us would attest to the fact that we feel better when we exercise. And ironically, we feel like we have more energy even after we exercise, not immediately after, but we feel like, we're taking care of our body and we have more energy. Another thing that is helpful in terms of treating depression is people being of service to other people. That one of the things that can happen that will cause people to feel better is being able to do things for others. So those are just some ways that mood disorders are treated. Next slide, please. In terms of special considerations for our population, I think I told you that past slide, 5 or more of those symptoms need to be present to diagnose it. The bar is a little bit lower for folks that have a developmental disability. 4 or more need to be present in order to make that kind of diagnosis. And of those 4, at least one has to be one of these 3. Depressed mood, it can be all 3, but it has to be at least one of these. Depressed mood, that anhedonia or loss of pleasure. And again, the one thing that you see that you have to be on the lookout for with our folks is irritability. Irritable mood isn't listed in the DSM-5 for the sort of normal neurotypical population as a symptom of depression, but for our folks, it certainly is, and that's one thing that you have to be on the lookout for. All right, next slide, please. Another mood disorder, so you had that unipolar depression just being on the depressive end with dysthymia and major depression, is now we're going to talk just rather briefly about bipolar disorder. So bipolar disorder is a combination of both ends of the spectrum of mood. So it's some depression and some what we call mania. And so we know what depression looks like. What does mania look like? And you need 3 or more of these, according to the diagnostic manual, to be able to diagnose something like bipolar disorder. Inflated self-esteem or grandiosity. Lots of times when people are in a manic episode, they think they are, sometimes they think they're famous people and it's a little bit psychotic and it's a little bit manic-y. Sometimes they think they can do superhuman things. Sometimes they'll tell you they've had almost superhuman accomplishments. That's grandiosity. I treated a bipolar young man before, and he used to tell me that that he was a professional basketball player. And I follow the basketball world pretty closely, having played and coached for years. And I knew he wasn't, but this was just his grandiosity when he was in a manic episode. Another symptom that we see of mania is decreased need for sleep. It's amazing what little sleep folks can get by on if they are in the midst of a manic episode. So usually, most of us sleep between probably 6 and 9 hours a night. We're talking about people in a manic episode sleeping 2 to 4, sometimes even less than 2 hours a night, and getting up and going about their day the next day. Talkative, or what we sometimes refer to as pressured speech. It's like they can't get enough words in, and they're talking super quickly. Their thoughts are racing. In that, they can't really organize their thoughts very well because they think one thing, then think another thing, and of course, they're saying what they're thinking. So it's kind of a word salad of a lot of verbalization. They're very distractible when they're in a manic episode. And down here, increase in goal-directed activity. One of the benefits, one of the things that people that have something like bipolar disorder will tell you that they like about being manic is they get a lot done. And lots of times that is true. They can do a lot of work. They can do a lot of housework. They can paint the entire house. They can engage in a lot of activities. The problem is with this last symptom, excessive involvement in activities that have high potential for painful consequences. The person's judgment isn't very good when they're in a manic episode. And so a lot of times you'll see people will drive way too fast, spend way too much money, gamble their life savings away, be involved in indiscriminate sexual activities, all of those things that can really have some negative consequences. And it really kind of hits them and when they're out of their manic episode and the ways in which they behaved. And so this is a very serious condition. This bipolar disorder is usually diagnosed a little bit later in life than schizophrenia, in that it's diagnosed typically in early to mid-adulthood. And Jen, again, will talk about treatment for bipolar disorder, but we have a lot of different what we call mood stabilizers that are used and antidepressants. Sometimes if a person needs to be safe from themselves and needs to be in a safe environment, hospitalization is necessary. And lots of times psychotherapy and education about bipolar disorder with the client themselves is very, very effective. Okay, next slide. In terms of special considerations for our population, instead of needing 3 of those symptoms from the previous page, you really need only 2. Sometimes, as you know, folks that have a developmental disability will report some exaggerated claims, but so sometimes we have to really do a good job of determining, is that just their sort of baseline thing that they do, or is it really changed, and do they now have even more grandiose ideas than they did before? And sometimes actually people will claim knowing important people, will claim doing important things. I had down here claims he was getting married, although not in a relationship. I remember having one client that I saw that had bipolar disorder that told me that she was married to both, at the time he was Governor Jerry Brown and comedian Jerry Lewis. So, she was obviously, that wasn't reality. She was not married at all, but in her manicness, she was believing those things. Okay, next slide. So with substance use disorders, and you'll see when we get to the next slide, this is true for the criteria that we have for these problems, these kind of mental health problems, are the same for neurotypicals as it is for our population. And really what it means is a problematic pattern of use. And in the diagnostic manual, you can have these kinds of substance use disorder. You can have alcohol use disorder, cannabis use disorder. You can even have, and some of us may even have this, caffeine use disorder, hallucinogen, inhalant, stimulant would be the methamphetamines, opioid, sedative, and tobacco. And the worse the pattern of use is, the more it tends to involve these 2 things of tolerance and withdrawal. And tolerance is, and we've all experienced this, I've certainly experienced this in my caffeine intake, that, you start out using the substance and it takes, X amount of the substance to get you to the feeling that you're going to feel from it. And the more time goes by that you're using it, the more that you develop a tolerance for that substance, and then you're going to need more of the substance to get the same effect. So people that are, alcoholic, for instance, or have what we call alcohol use disorder, they would not start out drinking, a fifth of vodka a day. They might start out with a beer and then graduate to 2 and graduate to 3 and graduate to 6 and graduate to hard liquor, and then get to the point where they're actually using an incredible amount because of their tolerance to the substance. And tolerance happens with most substances. The other thing that happens when a substance use disorder is more severe is withdrawal, which means that when you don't have the substance, you experience a set of symptoms, both physical certainly, and sometimes psychological, that will let you know that you don't have the substance on board anymore. So for instance, the DTs with alcohol use disorder are an example of withdrawal, that when the person that has alcohol use disorder is without alcohol for a certain period of time, they may experience that withdrawal syndrome called delirium tremens, or DTs. And so these are, there's substance use in the DD population, just like there is in the neurotypical population. Treatment for substance use disorders, sometimes medication is used. 12-step programs, 12-step meetings are used and actually are very effective. It's been difficult for researchers to study 12-step programs because 12-step programs, as you know, are anonymous. So it's really difficult to get in there and do a lot of deep research about these programs, but they're very helpful to people. Sometimes people need residential settings to remove themselves from the temptation of using. And there's a fair number of residential programs out there. And sometimes people are able to use outpatient counseling to help you deal with substance use disorders. All right, next slide. And like I said, really, there's no special considerations with our DD population. It's diagnosed the same way. It's manifested the same way with, a dysfunctional pattern of use, and then those two hallmark things of tolerance and withdrawal. Next slide, please. And the last one that I'm going to discuss today, and then I'll leave a few minutes for questions, are eating disorders. And eating disorders, we see two main ones. And I don't have Prader-Willi here. Prader-Willi is a medical condition. It's not a condition in the DSM and the diagnostic manual that psychiatrists and psychologists use, but it is certainly an eating condition. But what I'm going to briefly talk about is anorexia and bulimia. Anorexia is when a person severely restricts their food intake. And usually this results in a significant loss of weight. Anorexia is kind of an interesting disorder in that when it was first actually identified, and this is years ago, it was categorized as a psychotic disorder. And it was categorized that way because people that had anorexia seemed to be so out of touch with reality, but really only in the area of how they viewed themselves and their bodies. Because a person with anorexia, we might look at them and say that person is, inordinately thin, is emaciated, and they can look like a concentration camp survivor, literally. And that same person themselves, if you were to ask them what their appearance is like, they would see themselves very, very differently, and would see themselves as being overweight typically and needing to lose weight. So it was initially considered a psychotic disorder. It really isn't now, but it is true that a person with anorexia, their own self-perception is very, very distorted. Interestingly, I remember attending a workshop years and years ago when a hospital that I did some work with had an eating disorder wing where they treated only eating disorder patients on that wing of the hospital. And they found out that when they would have, let's say, 5 or 6 folks with anorexia already on the unit, and they accepted a new patient into treatment, all the other anorexic patients would say that person is really, really thin. And then if you ask them, but what about you? And they'd say, but I'm overweight and I need to lose weight. So their reality testing for others was pretty accurate. The reality testing in terms of their own perceptions of themselves was not accurate at all. And in fact, was really out of touch with reality and psychotic. Sometimes with anorexia, hospitalization has to be used to treat this, because people can kill themselves by restricting their food intake for too much over too long a period of time. So there's, depending on who you read, there's usually about a 5 to 15% mortality rate for anorexia. So it is something that really needs to be considered seriously, and oftentimes folks have to learn that at their worst might have to be hospitalized and even fed intravenously so they survive. So it's a really serious eating disorder. Bulimia is the eating disorder where a person consumes a lot of quantity and a lot of calories of food, and then feels guilty and purges. So it's that binge and purge syndrome. And you can imagine how unhealthy for the body doing something like binging and purging is. And bulimics do that, over time. So it's this real sort of lack of control over their eating, and then an excessive feeling of guilt, and then feeling like they need to do something to sort of undo all the eating that they did, which is to purge. And lots of times, if a person's bulimic for a long enough period of time, they've probably trained themselves to almost regurgitate on demand. So this is another serious disorder. This is a disorder actually that if you were to poll college counseling centers on college campuses across the country, they would tell you that they see a lot of a lot of bulimia on college campuses, that it's a serious disorder. So some medication can be used, particularly if there's anxiety or depression connected with either of those eating disorders, and lots of times there are. Hospitalization, like I said, particularly for anorexia. Outpatient therapy and family therapy is used a lot for both of those eating disorders. Next slide, please. And are there any special considerations for a DD population? No, there are not. So anyway, so those are the 4 categories of disorders that I wanted to discuss today: psychotic disorders, mood disorders, which include depression, dysthymia, bipolar disorder, substance use disorders, and eating disorders. I realize it's a pretty quick overview. I know we have about 5 or 10 minutes left, and I'm very happy to entertain any and all questions if you have them.
Hi, this is Nancy. Just a quick question, Dr. Boyle. So
yeah.
When is it, or do we ever do any kind of neurocognitive testing on children for eligibility reasons?
So let me just clarify with you. When you're asking about neurocognitive, what are you asking about, Nancy?
So for example, let's say a parent adopted a child who had a lot of, who had exposure to drugs and alcohol in utero. Mm-hmm. And let's say that's the only thing they know about the child. Mm-hmm. I worked at another place that did neurocognitive testing, and I just wondered, what is the regional center's take on doing that kind of testing?
So neurocognitive testing, if by that you mean sort of the gamut of both cognitive testing and other kinds of, achievement testing, things like that, to get a picture of the child and how they're functioning, that's all well and good. The testing that we do as part of eligibility really has to relate to the conditions that are regional center eligible conditions. And those, of course, are, and I think everybody knows this, ID and autism and cerebral palsy and uncontrolled seizures. And the thing where we sometimes see, like, let's say a child has something like FAS, fetal alcohol syndrome.
Right.
Sometimes they are eligible in our 5th category, which is a condition similar to an intellectual disability or requires services similar to, because sometimes those kids will not on IQ testing will score above the cutoff of what's considered to be intellectual disability, but maybe not much, and maybe they're borderline intellectual functioning in most areas. And that kind of child, and sometimes it's a child that's been exposed to substances or so forth, then that kind of information from neurocognitive testing could be information that we could use to help either decide that they would be or decide that they wouldn't be. We get some reports of neurocognitive evaluations where it's mainly brain-based kinds of tests that are used that might give us some information, but might not be completely relevant to the eligibility question. So, but usually those reports are helpful in that they do provide some information for us.
Okay, thank you.
Okay, you're welcome. Any other questions?
I don't see any questions in the chat box, but if you want to type your question there, we are looking. Okay, well, I don't see any more questions, Dr. Boyle.
Okay.
Do you feel like we should go ahead and wrap it up?
Certainly.
All right, well, thank you so much for that presentation. It was wonderful information, and I see there's lots of thank yous in the chat box, and I really appreciate everybody coming today. Our next class will be in August. We do these, going to do these every second Wednesday of the month. So that would be August 10th. And as Dr. Boyle said, we'll be talking about the medications that are commonly used to treat psychiatric disorders, psychotic disorders, mood disorders, and depression. So we'll be looking forward to seeing you all then. Again, if you didn't put your full name in the chat and who you work